patient and how it sort of impacts disease. So in the acute infection, which everyone who gets an H. pylori infection develops, you have increased SST, somatostatin, decreased gastrin, and decreased acid production. This is a short-lived acute infection. And so then you have this chronic infection, this chronic gastritis that can then develop, and it can either be a pan-gastritis or an antral gastritis. And if you develop this pan-gastritis, you have that same increased SST and ultimately decreased acidity. That's compared to the antral predominant gastritis, which is less common, about 15% of cases, where you have decreased somatostatin, where the D cells are, which secrete the somatostatin. So SST is decreased, your gastrin increases, and you have increased acid. And so how do these two different sort of phenotypes predict disease? So in that pan-gastritis case, you have chronic inflammation, atrophy, intestinal metaplasia, which is more commonly associated with gastric ulcers and gastric cancer. And then in the antral predominant, this is the one with the higher acid level. This is associated with duodenal ulcers. So you have a higher acid secretion, which flows into the duodenum and is associated with duodenal ulcers. So it's believed to be a stepwise progression. You have this normal mucosa, it gets infected, you develop this chronic active gastritis. A bunch of other factors will play into determining whether patients develop the atrophy, the intestinal metaplasia, the dysplasia, and ultimately the gastric cancer. And again, just these additional environmental factors which can play a role in all of this. When we look at infections, viral or bacterial, that are associated with cancers, whether you look at less developed regions or more developed regions, we see that the dark gray box at the bottom, H. pylori, is associated with gastric cancer. You know, we have above that Hep B and C associated with hepatocellular carcinoma, HPV, and other infectious agents. So this has led the World Health Organization to label H. pylori as a class 1 carcinogen for gastric cancer, and specifically non-cardiac gastric cancers, where it's been implicated as causative in 89% of cases. This is sort of a compilation of studies that have looked at eradication programs. There's, I think, 4 from China, 1 from Japan, and 1 from Colombia that looked at eradication programs and how it sort of fares in relation to development of gastric cancer. And it appears to be a protective effect. If you initiate an eradication program, it can actually protect against gastric cancer. And I think the jury is still out on the feasibility and applicability of this. The authors in that article say that before embracing a large-scale eradication program, there are some unresolved questions, including cost, feasibility, which groups are you going to target? Do you target the entire population? And is there a potential harm of mass therapy with antibiotics? The infection has been around for over 600,000 years, and what is the effect of now eliminating that infection? And they also state that it requires region-specific and cost-benefit analyses before moving forward with something like that. Also, there are some believed benefits to H. pylori. We know that it protects against acid reflux and thereby protects against Barrett's esophagus, esophageal adenocarcinoma, and asthma. So if you're thinking about getting rid of this organism completely, you have to take this into account as well. So the last section is sort of why I decided to give this talk, is because there are new guidelines on treatment of H. pylori, and so we'll go into that. There are 2 different consensus guidelines, Canadian one from 2016 and an American one from this year, that looked at sort of the newest data and the guidelines on how to approach a patient who's infected with H. pylori. So first, I want to just mention we've heard of test and treat, and I really sort of think it should be test then treat. So test first for infection, confirm infection before you treat a patient. do not empirically treat. You might see that, you know, on an exam question, actually. That comes up a lot. Empirically treat the patient for H. pylori infection. That's never the answer. At least there isn't enough data to support that. And the reason is it's just more cost effective to first test and then treat. Data is, of course, limited. So who do we test? And there are strong and conditional recommendations in the guidelines. So patients with active or confirmed history of peptic ulcer disease, you should treat. Why? Because it cures and prevents ulcers. Patients with multiple lymphoma, you should treat. Why? Because it actually leads to tumor regression. That tumor regression isn't indefinite, but at least in the short term, the tumors, many of these lymphomas will regress after you treat for H. pylori. Patients who have had a gastric cancer diagnosis, who've been resected, you should treat. And why? Because it leads to fewer metachronous cancers of the stomach in the future. Patients in whom you're planning to initiate chronic NSAIDs, test before initiating. And then lastly, if you're performing an EGD for dyspepsia, the American guidelines say to perform gastric biopsies. If you're in there, you might as well take a few biopsies to rule out that as a possibility. So those are the recommended, these are the conditional recommendations. So a little less strong data to support these, but patients who have uninvestigated dyspepsia are aged less than 60 without alarm features, you should test for H. pylori. Long-term aspirin users, so we see these in GI clinic a lot, patients who have just been started on aspirin and were never really tested for H. pylori. You know, NSAIDs of any sort plus H. pylori can increase your risk further of peptic ulcer disease, so that's the reason to test. Patients already on chronic NSAIDs, patients with unexplained iron deficiency anemia. We know that a small percentage of patients with this entity have H. pylori infection. You treat the infection, the anemia gets better. It's felt that the infection can affect iron absorption, so treating it makes it get better. Idiopathic thrombocytopenic purpura, the reason H. pylori infection is associated with this is really poorly understood, but in some patients with ITP, treating the H. pylori can actually make the platelet count go up. And who not to test? So guidelines say that patients who have typical GERD symptoms, so reflux or heartburn, without dyspepsia should not be treated. And we also know that H. pylori can be protective against GERD. Family history of gastric cancer. So you have a family history of someone, and should you be testing their family members for H. pylori, the guidelines suggest against it. Okay, so how do we test? If we are deciding to test, we have non-endoscopic and endoscopic options. So among the non-endoscopic options, the two with the highest sensitivity and specificity are the urea breath test and the stool antigen assay. Pretty sort of similar in sensitivity, specificity, and cost, and really sort of limited limitations. IgG serology is really something that we should be avoiding unless we really have a high pretest probability. So maybe you're doing an endoscopy on a patient are used commonly. So the guidelines also state that you should offer treatment to all with active infection. We already know sort of the effects of the infection, sort of serious implications of an untreated infection. And they have this long list of options, and I'm not going to go into each of these options, but they do break it up into recommended, and by recommended they mean preferred, and suggested. And so there's more data looking at these three, and these are the three recommended. So these are the ones that I'll focus on, and they are clarithromycin triple therapy, the one that used to be first line and still remains first line, bismuth quadruple therapy, and concomitant therapy. And concomitant therapy is also called non-bismuth quadruple therapy. So before deciding on a first-line regimen, which of these should I use, they suggest you ask yourself 3 questions. Is there a penicillin allergy? And really, is there a true penicillin allergy? So a lot of patients carry these penicillin allergies on their chart that really aren't true allergic reactions that they've developed. So if yes, obviously avoid amoxicillin and consider metronidazole as an alternative. Has there been previous macrolide exposure for any reason? So a lot of times that the answer to this is yes. And if yes, you should be avoiding clarithromycin because there's such high resistance, H. pylori resistance to clarithromycin. When we look at United States data, 1 outpatient antibiotic script per person per year has been prescribed. That's from 2013. And the most frequently prescribed is azithromycin. So a lot of patients have actually been exposed to macrolides. And lastly, the third question to ask is clarithromycin resistance rate greater than 15? And we don't have a lot of US data on this. I think we're behind compared to Europe when looking at H. pylori resistance rates. But we do have some data from the Houston VA that looked at this, and we know that among H. pylori resistance, metronidazole, clarithromycin, and levofloxacin are the most common. Amoxicillin actually has a low resistance rate along with tetracycline and rifabutin. But even looking at clarithromycin, at least in the Houston area, that already exceeds 15%. So that might be a regimen you would avoid in that population. So this is sort of the decision tree you would take. First, let's look at patients who have a penicillin in 2005. More recent studies have shown that quadruple therapy is actually more effective at treating H. pylori compared to, and this is bismuth quadruple therapy, compared to triple therapy. Treatment regimen duration, how long should we be treating patients for? And when we look at 14 versus 7 or 10 versus 7 or 14 versus 10, the longer duration of therapy seems to win in a lot of these side-by-side comparisons. So longer duration, consider quadruple therapy. There is this sort of entity of sequential therapies where you'll do PPI plus amoxicillin and then another combination of drugs a few days later. And they've looked at that, and this used to be very popular in Europe, and it seems when you compare these data that the sequential therapy doesn't work as well as concomitant. That's not to say it's not an option, but if you're going to choose a therapy, choose a concomitant therapy, one in which all the medicines are used all at once rather than sequentially. Of course, this sort of title makes sense, but a culture-guided regimen is more effective. When you look at regimens that are guided by culture and resistance, and you dictate your regimen based on that, of course, it's more effective. But the problem is that resistance data and testing is not widely available. As I said, we just sent our first patient for this, and we still don't know what the outcomes will be. And rather, they suggest to use local experience and the patient history of prior antibiotics to really guide. Another important thing that sometimes I think we, even in GI, forget is to discuss the side effects to improve compliance. So when you look at 2 groups where a control group versus a group where the side effects were discussed, the meds that were taken were many more in those patients who were explained the potential side effects before they started the treatment. Taking more meds means you take it for a longer duration, and we already know that longer duration works better. The common symptoms, nausea, dyspepsia, abdominal pain, diarrhea, should be explained to patients. So confirming eradication, when do we do this and whom do we do it? So really in every patient who you treat for H. pylori, you really should be confirming eradication, and I think that's one of the new details of these guidelines that weren't previously published. So perform the test over 4 weeks after completing treatment. You should really stop the PPI for 1 to 2 weeks before testing. That can create a false negative if they're on the PPI. You should also stop bismuth and antibiotics 4 weeks before testing. And the tests to use are the breath test, the fecal antigen test, or endoscopic testing. Obviously, most expensive because of the procedure, but all of these are feasible ways to confirm eradication. In patients in whom treatment failed, there are some predictors of failure: cigarette smoking, diabetes, obviously antibiotic resistance. There are salvage therapy options, which includes, again, bismuth quadruple therapy and levofloxacin-based therapy. Resistance testing is focused on levofloxacin and clarithromycin. These are PCR or fish analysis studies, but again, limited in availability. And after a true cure, reinfection is actually unusual, less than 2% per year. This is in the guidelines. I won't go into the details, but it sort of guides you on salvage therapies after you've tried maybe this regimen, clarithromycin triple or bismuth quadruple, and have down ethnicity and socioeconomics. We know that in some parts of the world, it's actually prevalence is stable. The organism itself is adapted to surviving in the acidic stomach. The extent of infection will dictate the physiology and the disease type that you'll develop. Infection leads to this gastritis, which can provoke serious GI disease. So test before treating, consider allergies and true allergies and prior antibiotic exposure. Quadruple therapy is better than triple therapy, and longer duration, 14-day duration, is better than shorter. And bismuth quadruple therapy is a reliable first-line regimen in almost all cases you would encounter. And finally, please confirm eradication 4 weeks after treating patients. These are some of the references to the 2 guidelines that recently came out. That's it.
Are there any advantages in H. pylori infection? Does it make a better quality of life?
I don't think we know too much about quality of life, but we do know that it can be protective against some of those other GI entities, right? So gastroesophageal reflux, it can protect against Barrett's, it can protect against esophageal adenocarcinoma.
What about cancer?
Of
anything?
So we, those associations, the non-cardiac gastric cancer, the malt lymphoma, are associations that once we make that diagnosis of the infection, we want to treat because of that risk.
Is there any other bacteria that you can think of that has the prevalence and the association with disease and health that H. pylori has?
In the U.S. or worldwide?
I didn't put any restriction.
I suppose tuberculosis has pretty serious implications outside the U.S.
Okay, thank you. Comments, questions? Please. You have a microphone.
It's interesting in one of the slides, and you're still talking about
Could
that.
you speak a little louder and directly into the microphone?
There is association between malt lymphoma, and we should screen for H. pylori to ameliorate or treat that. It's fascinating because malt lymphoma in rheumatology is associated with Sjogren's disease or syndrome. So once we have Sjogren, if the patient is not really symptomatic, should we screen them for H. pylori in an attempt to prevent malt lymphoma as an etiology?
So the question was, should we be screening patients to prevent malt lymphoma?
And Sjogren disease in particular, because there is association between malt lymphoma and Sjogren's disease.
Oh, in Sjogren's disease. Oh, yeah, I didn't know about that association. Oh, yeah. Yeah, I'm not actually sure. Malt lymphoma is so sort of rare compared to these other entities that I don't even know that we would have the significant numbers to really prove that. But, certainly in patients who have the diagnosis of malt lymphoma, the practices to test and treat for H. pylori.
Okay.
Excellent